moving on to this topic, management of FSGS. So this FSGS, which we see, is a very common finding which we get in the biopsy. So how to manage it, how to approach it clinically, that I'll be going. So basically, FSGS is a pattern of injury which is driven by various etiologies. It is known by various synonyms: focal and segmental glomerular sclerosis with cyanosis, focal sclerosing glomerulonephritis, and focal sclerosing glomerulopathy. And it is called FSGS because it affects only some glomeruli. So it is focal and it affects only parts of glomerular cleft, and so it is called segmental. And FSGS is a leading cause of ESRD in children who are aged 0 to 19. So clinically, in most of the patients, it presents as nephrotic range proteinuria, especially the primary FSGS. In 90% of the children and 70% of adults, it presents as microscopic hematuria in 55% of the children and 45% of adults, and it presents as hypertension with 30 to 65% of the patient, and in around 20% of children and 30% of adults, FSGS presents with renal insufficiency. So different histological patterns of FSGS may display different clinical features. So I think all of you are very familiar with this classification, which is the Columbia classification, which is proposed by Dagatti and colleagues. So the thing is, like, this has to be read from bottom to the top. So first thing, so this is basically a histopathological classification of FSGS. So first thing we have to look is that is there a glomerulus with collapse and podocyte hypertrophy. If that is ruled out, the next is tip variant. If you rule out a tip variant, then we have to go for cellular variant. Next is perihilar variant. Next is FSGS NOS. So this is the order in which we have to read or look for FSGS, and this is how the classification goes. I'm not going into the pathological details because we will be focusing mainly on the treatment aspects. So what is the implication of this Dagatti or Columbia classification? So the thing is, like, we can get some inference on the prognosis of the disease. One is if it is a perihilar variant, it is usually seen in maladaptive forms of FSGS. And if it is a tip variant, it has got good prognosis among primary FSGS. And the collapsing variant has got poor prognosis. Other than this classification of FSGS, it does not reflect any practicalities surrounding the treatment approaches to patients who are having FSGS lesion in kidney biopsy. So for that, the KDIGO 2021 working group, they have proposed this clinical pathological classification of FSGS, by which we can practically approach a FSGS lesion when we see it in a light microscopy. So whenever we see an FSGS lesion in light microscopy, the next we have to bring in the clinical parameters. If it is associated with nephrotic syndrome, usually sudden onset nephrotic syndrome, and it is amenable to therapy, and in the electron microscopy, they will have diffuse food process effacement, then it is likely to be primary FSGS. Next is a secondary FSGS. Usually they will have proteinuria, but they won't have nephrotic syndrome. Nephrotic syndrome is unusual in secondary FSGS. And if it is secondary, we have to look for viral as well as drug-induced as well as maladaptive forms of FSGS. I will be describing it. And next we have to consider is the genetic FSGS, if it is familial, syndromic, or sporadic. If you find a pattern of proteinuria without nephrotic syndrome and electron microscopy shows segmental food process effacement and there is no evident secondary cause, then it can be labeled as FSGS UC or FSGS of undetermined cause. So this is the etiological classification. As we know, primary FSGS is probably mediated by a circulating permeability factor, and in the secondary FSGS, the main things which we have to rule out is a virus or the drug-induced. Among the virus, the HIV, parvovirus, SV40, cytomegalovirus, and we have seen a lot of FSGS during the COVID period. COVID can be a cause of FSGS. And the drug-induced, mainly the drugs which are encountered are lithium, palmitronate, sirolimus, anabolic steroids, heroin. So all these drug history has to be taken. And the adaptive forms of FSGS, those which have reduced renal mass at birth, which include oligomeganephronia, unilateral renal agencies, renal dysplasia, and those patients who have initial normal renal mass consisting of it contains hypertension, obesity, increased lean body mass, cyanotic congenital heart disease, and sickle cell anemia. And those patients with familial or genetic FSGS, these are the common mutations: nephrin, podocin, alpha-actin 4, TRPC6, WT1. So just a word about the primary FSGS. There is evidence that primary FSGS is due to the presence of a circulating permeability factor. So these are the clinical observations. That means there's an immediate recurrence of proteinuria which occurs after transplant. There is efficacy of plasmapheresis. Immunoabsorption can be useful in reducing the proteinuria. And the experimental findings which support this is that there is induction of proteinuria in rat after injection of FSGS serum or plasma. And there is increased glomerular permeability after incubation. And the factor has not yet been identified, but SUPAR or soluble urokinase plasminogen activated receptor, it is increased in FSGS plasma. And also the CLC1 can be another factor which can be present in primary FSGS. So when we see a patient with FSGS, this patient usually has hypertension. So it usually becomes a dilemma, like whether it's like the egg or the hen story, which one came first. So these are some clues, like hypertension can cause some secondary FSGS, or is it the FSGS which has caused hypertension in that patient? So usually primary FSGS presenting as hypertension, they will have some nephrotic syndrome. They usually present as nephrotic syndrome with abrupt onset, massive proteinuria. But in hypertension causing FSGS, they will be usually having, they won't be having massive proteinuria or nephrotic syndrome. They will be having only subnephrotic proteinuria usually. And this is another major differentiating factor. Here the glomeruli will be usually shrunken in hypertension related FSGS. But in other forms of maladaptive FSGS, the glomerular tufts are usually enlarged and there will be glomerulomegaly in those cases. And the other arteriolar changes associated with hypertension, mainly the afferent arteriolar hyalinosis, that will be usually present in hypertension related FSGS. And this is another causative factor for FSGS, obesity associated FSGS. We know obesity is associated with increased renal blood flow, glomerular filtration rate, and microalbuminuria. And many causative factors are implicated. It can be due to increased renal venous pressure, hyperlipidemia, increased production of vasoactive and fibrogenic substances which are produced from the adipocytes, including the substances like insulin, leptin, and TGF1. And here also the differentiating factor from primary FSGS is that it presents as slowly progressive proteinuria, and usually the proteinuria will be in a subnephrotic range, and full nephrotic syndrome is unusual. In all these conditions, it is usually the perihilar variant which is more common. And a word about the APOL1 associated FSGS, which is not common in our part of the world. It is a major form of FSGS present in the African descent, and it has an autosomal recessive inheritance patterns, and it triggers 2 risk alleles. And the APOL1 associated FSGS can present in either of the 3 ways actually. One is primary FSGS with severe nephrotic syndrome. It can just present as a recurrence after kidney transplant. It can present as adaptive FSGS with preserved serum albumin and minimal edema. And this thing has to be kept in mind. It is strongly associated with collapsing glomerulopathy, especially in several settings like HIV-associated nephropathy, exogenous interferons, and lupus. And this APOL1 associated FSGS is associated with more rapid progression to end-stage renal disease. And about the genetic forms of FSGS, it can present in either childhood or adulthood, but mostly it presents in childhood. And this can have a variable range of clinical presentation. It can present with variable proteinuria. It can have in electron microscopy, it can present with either diffuse food process effacement or just segmental food process effacement. And it can be a renal limited presentation or it can be part of a syndrome. If it is renal limited, the genes that are expressed in the podocyte like NPHS1 or the nephrin or the podocin gene are involved. But if it is a syndromic presentation, it usually results from genes expressed in tissues which are present in tissues other than the kidney, other than the podocyte, like WT1 gene, LMP2 gene, LMX1 beta gene. So these are some of the genes which are involved in FSGS. I'm not going into detail, just to look at the syndromes, like if it is nephrin, podocin, usually presents as congenital nephrotic syndrome. This tubulin mutation can present with megaloblastic anemia and childhood onset nephrotic syndrome, and integrin beta 4 mutation can present with epidermolysis bullosa, atresia pylorus, and early onset FSGS. So we have to look into all these syndromic manifestations. So what are the indications of genetic testing? So actually, with the identification of a vast variety of genes, especially with the next generation sequencing which are now available, the indications of genetic testing have actually gone up nowadays compared to the previous things. Here it is like if kidney biopsy shows nephrotic syndrome with diffuse food process effacement, then it is likely to be primary FSGS. So we can go with steroids as a first line treatment. But whenever it shows a steroid resistance, then go for genetic testing. But if there is no nephrotic syndrome, but electron microscopy shows diffuse food process effacement, in that case also, it is likely to be genetic variant. So we can go with genetic testing. And here, when there is no nephrotic syndrome, but it presents with segmental food process effacement. So whenever it is segmental, it is always likely to be a secondary thing. Okay, so secondary causes we can rule out. If there is no evidence, if there are secondary causes are evident, then it is secondary FSGS. But in the same scenario, if there is no evidence of any secondary causes, then also go for genetic testing. So what are the implications of doing genetic testing in these patients? So one is like when there's a strong family history and clinical features suggestive of a syndromal disease, we have to go for it. And the main thing is like most of these genetic variants are not responsive to corticosteroids. So if you find that it is a genetic variant, we can limit the corticosteroid or immunosuppression exposure. So that should be our main aim. And next thing is like especially when they are going for a transplant. So it can determine the risk of recurrence in kidney transplant. For example, most of the genetic forms of FSGS are they doesn't recur in the post-transplant period. But for some exceptions are there, including the nephrin and the podopsin, especially the nephrin NPHS1 mutation. Those patients can have anti-nephrin antibodies in their serum. So it can act as the nephrin inside the donor kidney, and it can produce a recurrence. So other than this, most of these variants does not recur in the post-transplant period. So with the genetic analysis, we can have an idea about the clinical course. We can give precise genetic counseling and have an idea about the post-transplant recurrence. So once we identify a patient who is having FSGS, we have to see the risk factors involved in the progression of FSGS to ESRD. So several clinical features are biopsy. One is severity of nephrotic range proteinuria, elevated serum creatinine, and black rays. And about the histopathological features, the collapsing variant of FSGS has got the worst prognosis. If there is in the tubulointerstitial fibrosis, then it has got worse prognosis. And also the clinical features during disease course. If they fail to achieve partial or complete remission during the course of treatment, then it has got a worse prognosis. And the sad thing is that approximately 50% of the untreated patients, they will reach end-stage renal disease by 10 years. And so this graph shows like how important is attainment of a clinical remission or some form of remission in a patient with primary FSGS. See here, if you look at the renal survival, those having a good complete response, the renal survival even at 15 years is very good. But it is better in those patients who have attained at least a partial remission compared to those patients who do not attain any form of remission at all or no remission. So here approximately 50% of them go into ESRD by 10 years from diagnosis. So going on to the treatment per se. So whenever we see an FSGS pattern, these are the things which you have to look into. One is a detailed drug history, a family history, body mass index has to be taken, birth weight if possible, if we could get the birth weight, and the viral serologies has to be done. And we have to look for clinical evidence for a syndromic presentation, especially any hearing loss, skin or eye abnormalities, cardiac dysfunction, hepatosplenomegaly. And after this, we go into the biopsy, light microscopy, immunofluorescence, and electron microscopy. So this is about the how the KDIGO 2021 guidelines. If there is a FSGS lesion on kidney biopsy, And if there is nephrotic syndrome, that is proteinuria more than 3.5 gram and serum albumin less than 3.5, and especially in the presence of diffuse food process effacement, then it is likely to primary FSGS, treat with immunosuppression. If no response, go for genetic testing. But if there is no nephrotic syndrome, that means there can be nephrotic range proteinuria, but serum albumin is more and proteinuria is less with or without hypoalemia. If there is no nephrotic syndrome, then in all those conditions, exclude the secondary forms of FSGS. Don't consider immediate immunosuppression in that case if there is no nephrotic syndrome. And in that case, we have to manage with supportive therapy in the form of diet restriction, salt and fluid restriction, and ACE/ARBs. So all this has to be done, and monitor proteinuria and serum albumin in that case. And we have to follow in case of worsening proteinuria and reduction in serum albumin, and the patient develops nephrotic syndrome. So that is the time when we have to treat the patient. So these are some of the definitions. I think most of you will be very aware of these definitions. Just a recap of that. Complete remission when the proteinuria is less than 0.3 and stable serum creatinine, serum albumin is more than 3.5. Partial remission means the proteinuria is reduced to 0.3 to 3.5 gram per deciliter, and there is a decrease more than 50% from baseline. And relapse is when the proteinuria is more than 3.5 gram per day after attaining complete remission, and or there is an increase in proteinuria by 50% during partial remission. And this is what which we are going to deal with mostly, the steroid resistant FSGS. So when there is persistence of proteinuria more than 3.5 gram per day with less than 50% reduction from baseline despite taking this dose of prednisolone for at least 16 weeks. So this 16 weeks is important in FSGS. Next is steroid dependent FSGS. That means if the patient develops a relapse during or within 2 weeks of completing glucocorticoid therapy, then it is a steroid dependent FSGS. Next is a CNI resistant FSGS. When the proteinuria persists more than 3.5 gram per day with only less than 50% reduction from baseline, despite having cyclosporine and tacrolimus at the target trough levels, and for 4 to 6 months. If they are having persistent proteinuria even after 4 to 6 months, then we can label it as CNI resistant FSGS. Next is CNI dependent FSGS, means relapse which occurs during or within 2 weeks of completing cyclosporine or tacrolimus therapy for more than 12 months. So these are some of the treatment recommendations for children with FSGS. So on presentation, it is always steroids, initially daily and then alternate days. If it is frequently relapsing or steroid dependent pattern, then also prednisolone daily and then to alternate day to lowest dose to prevent the relapse. But if the patient has steroid related side effects, then we can try these agents like cyclophosphamide, calcineurin inhibitor, levonisole, MMF. If it is a steroid resistance mainly, then CNIs are preferred. So I'll be mainly dealing with the adult part of it. So if the patient presents with nephrotic forms, APOL1 associated FSGS, certain steroid sensitive forms of FSGS, in that case prednisolone initially daily or alternate day. And here there is a recommendation to, when there is patient is at high risk for steroid complications like diabetes, obesity. In that case, we can go for calcineurin inhibitors as a first line therapy. When it is a steroid resistant FSGS with a nephrotic syndrome, in that case, CNIs are the preferred first line therapy. When it is a refractory FSGS with nephrotic syndrome, in that case, there is not much evidence, not much RCTs are there. What can be tried is MMF plus high dose dexamethasone. And in all other forms of FSGS with subnephrotic range proteinuria, ACE inhibitors, ARB, dietary sodium restriction, and even pyruvate diuretics can be tried, which can potentiate the antiproteinuric effect of RAS. So this is how we have to go with steroids. It is recommended that high dose steroids can be used as a first line therapy. And there are only low quality RCTs and observation studies. And this is the dose 1 mg per kg, maximum 80 mg or 2 mg per kg on alternate day. And this has to be continued for at least 4 weeks or until CR is achieved or 16 weeks. So that means if the patient on high dose steroid is to attain complete remission by 3 weeks, then we have to continue for till the 5th week. That means for 2 more weeks after the disappearance of proteinuria. Or if the patient attains a complete remission very early, as early as the 1st week, then we have to give for at least 4 weeks. So minimum 4 weeks or 2 weeks after the disappearance of proteinuria, whichever is longer. And after that, we have to reduce the dose by 5 mg every 1 to 2 weeks, and they have to complete a total duration of minimum 6 months duration. And if the only partial remission is attained within 8 to 12 weeks, continue until 16 weeks, and then taper over 6 months. If there is no remission even after 16 weeks, then taper the steroids and start CNIs. So that's about the recommendation for steroids. Next, going on to CNIs. So in those patients who have relative contraindications to steroids, alternative immunosuppression with CNIs should be considered as the initial therapy in patients with primary FSGS. And for CNIs, cyclosporine, the dose recommended is 3 to 5 mg per kg per day in 2 divided doses, or tacrolimus 0.05 to 0.1 mg per kg per day. And these are the target trough levels which are to be attained: 100 to 175 and tacrolimus 5 to 10. And the total duration for determining CNI efficiency that should be given for at least 6 months before we deem them as CNI resistant. And the total duration of treatment which should be given if their CNI response is like at least for 12 months with attaining a target trough level of CNI. And after attaining 12 months, then they should be tapered over a slow course of 6 to 12 months. So according to these guidelines, the minimum duration of treatment with CNI goes for at least 1.5 to 2 years. And this was one of the earlier studies by Dimitros et al., which showed that immunosuppressive therapy of idiopathic FSGS will be effective. So this in this it is treated with primary FSGS was treated with randomized to prednisolone alone, prednisolone with azathioprine, prednisolone with cyclosporine. And what I found out from the study is that this remission was observed more frequently among those who are treated versus not treated. And remission with prednisolone was found in 62%, whereas combination of prednisolone with aza was 80% of remission of nephrotic syndrome, and combination of prednisolone with cyclosporine brought about remission in 85% of the patients. So this was a study which suggested that steroid and immunosuppressive agents have a role in amelioration of clinical course and remission of nephrotic syndrome in FSGS. And this is another study by Duncan et al., which showed the role of tacrolimus monotherapy in adults with FSGS. Here there were two groups. One was a group of patients who was treated solely with tacrolimus, and second was another group of patients who were initially on cyclosporine, who had attained remission on cyclosporine, but later they were later, as the eGFR was steadily declining on cyclosporine, they were converted to tacrolimus. And the results are like all the patients who were on tacrolimus attained remission. There was significant reduction in 24-hour protein excretion, but all the remissions were partial. And in the cyclosporine to the TAC converted group, and 2 of the patients maintained complete remission. The remaining 3 in partial remission had further reductions in proteinuria. So this showed that there can be an improvement in renal function concomitant in conversion to TAC. So with this study, it concluded that the tacrolimus rapidly and effectively induced remission in FSGS, and conversion from cyclosporine to TAC indicates that TAC can be a more potent agent in the setting of worsening glomerular filtration rate. So going on to the steroid-resistant nephrotic syndrome, here the guidelines say that corticosteroid-resistant primary FSGS, we can give cyclosporine or tacrolimus for at least 6 months, rather than continuing with corticosteroid monotherapy or not taking. And RCTs are only there with cyclosporine. There are only uncontrolled trials with tacrolimus. So adults with corticosteroid-resistant FSGS should receive a minimum of 12 months to prevent the risk of relapses. So this is a study by Catran et al., which showed role of cyclosporine in steroid-resistant forms of FSGS. Here there are 49 cases of steroid-resistant FSGS. They were randomized to 26 weeks of cyclosporine and low-dose prednisolone versus placebo versus prednisolone. And the observations were like 70% of the group versus 4% of placebo had partial or complete remission by 26 weeks. And those in 52 weeks, relapse occurred in 40%, and by 78 weeks, 60% of these patients who attained remission with cyclosporine, they got a relapse. And there was a reduction in creatinine clearance, which is statistically significant in the cyclosporine versus no cyclosporine group. So it concluded that cyclosporine can be an effective therapeutic agent in steroid-resistant FSGS. But a higher rate of relapse can occur, but a long-term decrease in proteinuria and preservation of filtration function were observed. So this is how we have to, the guidelines say there is lack of quality evidence for any specific alternative agents when patient is intolerant to CNIs. What we can try is like MMF and high dose dexamethasone, rituximab, ACTH. All these can be considered. But in all these conditions, the treatment will have to be personalized. It is dependent on the availability of drugs and resources and the benefits of further treatment and risk of immunosuppression. And in that case, patient should be referred to specialized center or they can be enrolled in some clinical trials. So this is the evidence for MMF. MMF can be used in cases of CNI resistance. But in the KDIGO 2012 guidelines, it was given as MMF plus DEXA was given as a 2C recommendation. But the problem was that the trial which dealt with MMF plus DEXA is severely underpowered. It did not fulfill the sample size criteria. So the 2021 work group told that it would be appropriate to remove the use of MMF as a clinical recommendation. But this can be considered as an alternative treatment possibility when all other therapeutic options have failed. If we use MMF, the dose is 750 to 1000 mg BD for 6 months along with low dose glucocorticoids. And this was the trial which described the role of MMF. Just that the thing was like 192 patients were enrolled, but only 138 patients were randomized. So it was a severely underpowered study. So the only positive thing was that it was there was no statistically significant difference between the MMF DEXA group compared to cyclosporine group. So this showed that the MMF DEXA is non-inferior to cyclosporine. But the small sample size have prevented detection of a moderate treatment effect. The next thing which has been tried is ACTH gel. There were only pilot trials and 29% remission rate was obtained in SDNS and SRNS. The dose given was 80 units subcutaneous twice weekly. And no comment was given about it in the KDIGO 2021 glomerulonephritis guidelines. This was the evidence for ACTH. See, there were 22 patients who received immunosuppression and 6 had steroid dependent, 15 had steroid resistant FSGS. And thing is like in this steroid resistant group, 29% experienced remission with ACTH. But the thing is like adverse events occurred in 21 of 24 patients. So ACTH gel may be a viable option for some patients with steroid resistant nephrotic syndrome. But further research and further studies are to be done. So next is rituximab. Even rituximab is not defined by the latest KDIGO guidelines, but it can be effective in children with SDNS and FRNS. So in those with glucocorticoid dependent disease, rituximab may work, but it is less effective when it is a glucocorticoid resistant disease. So the drug importance is mainly on reducing the dose of steroids and as a CNS sparing agent. If you give rituximab, it's in the same dose as was tried for the membranous nephropathy, 375 mg per meter square weekly once for 4 weeks, or 1 gram after 2 weeks. So this was the trial of rituximab in adult patients with steroid-resistant nephrotic syndrome. So as told, like in steroid resistance, the results were not good. Only a minority of patients showed a positive influence of rituximab. So these are some of the other options which may be tried. One is plasmapheresis. There are conflicting reports from studies. It may be considered in those patients with primary FSGS who have continued massive proteinuria and hypoalemia despite exposure to an adequate course of all these agents, prednisolone, CNI, MMF, rituximab, and it should be used in conjunction with immunosuppression. And this is another thing, the LDL apheresis. There are several small non-randomized studies of LDL apheresis in patients in glucocorticoid resistant FSGS, and these studies have shown reduction in proteinuria and improvement in serum albumin. The mechanism is not known. It may be due to reduction in oxidized LDL and associated inflammatory cytokines, as well as some improvement in the hypercoagulability. So this is how we have to deal with FSGS. If it is a primary, all forms RAS blockade, optimal BP control, dietary salt restriction. The role of SGLT2 inhibitor, mineralocorticoid receptor antagonist, there are no studies, but we may try it. So primary FSGS, we can deal with glucocorticoid CNI. Secondary FSGS, underlying condition, antiviral agents. Genetic FSGS, targeted treatment. For example, some forms respond to coenzyme Q10 supplementation, so that may be tried. Some may be steroid responsive, so that may be tried. So next is FSGS of undetermined cause. In that case, consider genetic testing and a rebiopsy may be tried. If progression happens despite all these, we can consider referral to a specialized center, or they can be enrolled in a clinical trial. So these are some of the upcoming drugs. One is ofatumumab, anti-CD20 humanized antibody. Frezoliumab, which is targeted against TGF-beta. Blaselimab, anti-CD40. And these are some of the ongoing trials with the dual endothelin receptor antagonist, sparsentan, atrasentan, TRPC5 channel inhibitor, SLIT2 agonist, APOL1 antagonist. So these are some of the ongoing drugs, but no evidence has been obtained till now. And a discussion about FSGS is incomplete when we discuss about without discussing about transplant in FSGS and post-transplant recurrence. But I'm not going into detail in this topic because that itself is a huge topic. So FSGS, the recurrence is around 15 to 50% post-transplant. The rates are low in genetic forms of FSGS. For example, NPHS2 mutation can have some early recurrence. Nephrin mutation can also have recurrence due to anti-nephrin antibodies. And there are some recipient factors that contribute to increased FSGS recurrence, including prior history of recurrence of FSGS, younger onset, rapid progression of FSGS, Caucasian race, African race. And this is how we can deal with a post-transplant FSGS. Like, we should prevent the recurrence. We can give serum albumin before transplant, but not much evidence for all these. Once they develop post-transplant FSGS, then plasmapheresis or high-dose immunosuppression may be tried, or even rituximab may be tried. Thank you.